Ladies and gentlemen, welcome to GIST TKI treatments and effects on memory. During this seminar, all participants will be in a listen-only mode. There will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. When you submit your question, it will be visible to all panelists but will not be visible to other attendees. Please remember the information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild, the VP of Program Services, and I am your moderator for today. I would like to introduce our presenters. Dr. Annette Dunsing is an Associate Professor of Pathology at the University of Pittsburgh School of Medicine, as well as member of the Cancer Therapeutics Program at the UPMC Hillman Cancer Center. Her research focuses on GIST as well as other sarcomas with the goal of identifying novel therapeutic approaches. Recently, Dr. Dunsing has teamed up with Dr. Robert Ferguson at UPMC HCC to study cognitive impairment in GIST patients treated with Gleevec and other tyrosine kinase inhibitors. Dr. Ferguson is a clinical psychologist and assistant professor of medicine with the Division of Hematology Oncology at the University of Pittsburgh School of Medicine and Hillman Cancer Center. His clinical and research interests are the treatment of cognitive effects of cancer, cancer survivorship, and palliative care. We're really excited for them to be here today, and I'd like to now turn it over to Annette to start us off. Thank you.
Okay, thank you. I hope everyone can hear me. So first of all, Sarah, thank you so much for this great introduction and also for inviting myself and also my colleague, Dr. Robert Ferguson, to do this webinar for LifeRef Group and all the patients and caregivers that are listening. So I wanted to just give you a really quick introduction to how we got to do this topic and the intro to today's presentation. So for those of you who do know me, you likely know me for my laboratory work, as just stated, where I mostly look for new rational treatments for GIST, especially when first and second line treatments have failed. And this is still my main line of research, and Dr. Ferguson is really today's expert of the topic. However, he comes from the breast cancer field. So I guess we have made a marriage in heaven here. So how did I get interested in this topic that we're talking about today? This was really sparked through my longstanding and ongoing involvement with the GIST patient community, such as LifeRef Group and all of you. And through participating in email lists, patient educations, and fundraising events, I kept hearing the term Gleevec brain and Gleevec fog and complaints about cognitive issues and fatigue likely associated with your treatment. But it was not until I heard a talk in a seminar of a colleague of ours, Dr. Beth Snitz of the Department of Neurology, in a seminar series organized by the Biobehavioral Oncology Program and its director, Dr. Dana Bofberg, that I thought that I could actually help address this myself with the help of my colleagues. So this topic took shape over a few years, and as we know now, is really important for GIST patients who have to take a medication lifelong, and this is different, obviously, from other chemotherapeutic agents. Those courses of therapy are stopped over after a while, and also with new medications that are developed for GIST and that even might have a more severe impact on cognitive impairment in the patient setting. So today, Dr. Ferguson and I are proud to present you with some of the work that or topics that we've been working on over the past few years, and also give you an introduction to cognitive impairment in cancer itself. So with that, I'm actually giving it over to Dr. Ferguson. Thank you.
Hi, thank you, Dr. Dunsing, and thanks everybody for joining in. We really appreciate your time, and thank you for inviting me. There should be a slide on your screen that says today's topics. I'm assuming that's showing up for everybody. And I'm going to just review what is this thing called cancer-related cognitive impairment. And after I get done that portion of the talk, which will be a little bit detailed, I'll hand it back to Dr. Dunsing, and we'll talk about cancer-related cognitive impairment in GIST and potential effects of TKI therapies. After that, I will go over the things that we are doing in clinical psychology and in oncology regarding cancer-related cognitive impairment to identify and treat the problem. We're making some good progress, and I'm happy to say that. And then, given that we're all social distancing now with the COVID-19 outbreak, there's some particular challenges for patients who've had cancer and are going through cancer treatments and managing the stress of all of this, and particularly as we begin to open up our economy and become active again. We'll go to the next slide, please. And this slide is talking about chemobrain. Years ago, there were some suspicions that most of the memory effects with cancer were due to chemotherapy, and to a large part that was true, but we'll go to the next slide. Cancer-related cognitive impairment is a term that we've developed, if we go to the next slide, from all of these other terms of chemobrain or cancer fog. As we go through this, I'll demonstrate that it's not just the effects of chemotherapy on memory and attention. Could be the cancer itself and genetic predispositions or genetic risk factors that could put people at greater risk for developing cancer-related cognitive impairment. We go to the next slide. I'm assuming everybody is seeing a slide with an arrow going across. Most of the memory and attention problems that arise from cancer or cancer therapies are quite mild, but they tend to last a long time. I want to emphasize it's not everybody who ends up with these problems. We don't know the exact prevalence rate, but we do know that the symptoms tend to be mild to moderate, but they get in the way and they interfere with performance on the job or with family. The darn thing is they tend to be quite persistent and can last for some survivors for many years. Next slide. And the next slide is cancer-related cognitive dysfunction. Just historically, this was first studied in the 1980s from a psychiatrist by name of Peter Silberfarb. I once worked for Dr. Silberfarb at Dartmouth Medical School in New Hampshire. And he was one of our first researchers to identify cognitive problems among breast cancer survivors who were going through chemotherapy at the time. And he noticed with standardized neuropsychological tests that there were deficits in verbal memory, remembering words, as well as processing speed. Now, that early observation had some problems because they didn't have a control group with which to compare, but they compared the test performances of the cancer patients to the normative sample for the test, so people presumably with no health problems. And they noticed a statistically significant difference or lower performance among the cancer survivors versus the test norm population. Later on in the 1990s, some more cross-sectional studies were done where the study design was a comparison of breast cancer patients who had gone through their surgery, chemotherapy, and were at least a year beyond their chemotherapy at the time. They were then compared to people who had the same diagnosis, but did not have chemotherapy. And usually there was a third arm of people without cancer. And they matched and controlled for age, education, IQ, factors that could affect neurocognitive performance on standardized tests of memory. And they found that about 50% of the individuals who had breast cancer and were exposed to chemotherapy had significantly lower memory test scores than those who didn't go through chemotherapy. And both cancer groups scored significantly lower than the healthy controls. The question was, well, what about people prior to being exposed to cancer treatment that at the time of diagnosis? And so a series of longitudinal studies were launched in the late 1980s through to today. And what we found was when we identified cancer patients at the time of diagnosis and we were able to test them prior to the initiation of cancer therapy, about 40% of individuals demonstrated some cognitive impairment. And these were tumors that were not in the brain or spinal cord or in the central nervous system, but they were solid tumors distant in the body. So this set off a lot of other hypotheses and investigations. Well, what is it about cancer itself that for some individuals can cause memory impairment? And of course, there are some confounds. If a person has an underlying health condition, such as heart disease or diabetes, that can contribute to vulnerability to cognitive problems. But most of those variables were very well controlled in those early studies. So we know it's not educational deficits or learning disabilities or a history of other neurologic or neuropsychiatric problems. Oftentimes you will hear people say, gee, well, you've been through a lot as a patient who's been diagnosed with cancer. It must be stress or anxiety, or you might be depressed. And sure, depression and anxiety disorders causes cognitive impairment, but those variables are well controlled in this research. So we do know that memory impairment will occur for some cancer survivors. It isn't just stress or depression or anxiety. And the symptoms are usually mild to moderate. And I suppose the good news here is when we follow patients over time, the memory performances don't tend to decline. So they tend to be very stable. Unfortunately, the symptoms are something that will interfere with everyday life. We go to the next slide, please. And at the top, you'll see verbal memory at the slide. That's one of the domains that tends to be affected pretty consistently across all this research. So verbal memory is remembering words in a conversation, or somebody gives you a list of names, or you meet somebody at a gathering, and it's difficult to remember their name again. A lot of us here have experienced tip of the tongue syndrome. This becomes more frequent with people that have reported cancer-related cognitive impairment where you just can't find that word, or you might misname an object, call it a completely different name. Remembering what was read, or sometimes trying to recall even old information like a mobile phone number or a PIN. Let's go to the next slide. Working memory is another memory domain that is affected by cancer and cancer therapy. Now, an example of working memory is sort of like RAM on a computer. If you're typing in a Word document and you don't hit the save button and you close out of that document, then you've lost the content that you wrote. So the examples of this is you want to go get an object in another room. Somebody says hello to you on the way to that other room. You go into the room. You don't remember what you came there for. Or you might skip a task in cooking, or forgetting a particular step in a series of complex steps or with tasks that you want to complete at the workplace or at home. Another domain that's affected is our attention. Now, there are different types of attention. There's focused attention. So right now you may be focused on the words that I'm saying. There's also divided attention. We could be driving in a car, listening to the words I'm saying, but you're also operating the vehicle. We know that many cancer survivors, well past their cessation of chemotherapy, will report difficulty following conversations, especially in small groups. So there may be an auditory processing problem. That's still under some investigation. but trying to pay attention to conversations has been reported. Also, a person might forget to take a particular step, such as taking that right-hand turn down the road. Their mind may be off on other thoughts, or they may be listening to something on the radio. And being easily distracted by noise is fairly common. Another domain of memory and attention or cognitive function of cancer-related cognitive impairment that's pretty consistently affected in the research is processing speed. So, for example, with trouble doing simple arithmetic quickly, or freezing when you're faced with a sudden decision, or trouble finding something on a shelf or on a computer screen quickly. So finding some visual information and then making some decision with that, or hearing something and having to answer quickly. These reaction times can be slowed. We're going to go to the next slide, and the next slide at the top says, how do we measure cancer-related cognitive impairment? And on the left-hand side of the slide, you'll see PROs at the top. That's patient-reported outcomes. These are the questionnaires that we often fill out at a doctor's office that may ask us about our pain, or about depressive symptoms, or anxiety, or about fatigue. Patient-reported outcomes are simple questionnaires. Is usually a rating scale, 0 to 4 or 1 to 5, on different symptoms. And patient-reported outcomes for cognitive impairment really just measures a person's perception of how their cognitive abilities are. They tend to correlate or be very strongly associated with fatigue, anxiety, depression. So it not only captures the person's perception of their memory problems, but also the emotional impact. The next way we measure memory and attention is with neuropsychological tests. These are usually standardized procedures, and they measure those domains that I just went over. And this is objective memory performance that we're observing. So for example, some neuropsychological tests, for people who've done them, they might remember or be asked to remember a list of words. Then they'll do another task, and maybe 15 minutes later or half hour later, you'll be asked to recall those same words. Then you might be asked to recall categories of the words, such as name all the animals or name all the vegetables in the list. So that's a test of verbal memory. You might do processing speed tests where you're asked to recognize patterns on a computer screen and react. With the research on cancer-related cognitive impairment, there's no gold standard of neuropsychological test measures, but there are some that are uniform across the research studies, and there's a greater convention of using a standardized battery now, so we can compare across groups of people with different types of cancer and who have been exposed to different types of treatment. If you go to the right-hand column of this slide, it says data on cancer-related cognitive impairment. Most of the research in the past 30 years has been conducted, predominantly with breast cancer. So almost 80% of our studies were with breast cancer patients who were either going through active treatment or were many years past completing active treatment. The samples were therefore predominantly female, given that only 2% of our breast cancer diagnoses are in men. We have limited data on testicular cancer or gynecologic cancers or colorectal and head and neck cancers. And also we do have more research that's been done on hematologic cancer, such as lymphoma or leukemia. There's very limited data on GIST. I'm only aware of one study that studied GIST patients, and there were only 4 in the sample. However, Dr. Dunsing will go over some initial research that we've been able to conduct on a much larger sample. We have very limited data on the effects of tyrosine kinase inhibitors and their effect on memory. But we think with our research that we've started with GIST patients, we'll get a better and clearer picture in the years to come. I'm going to the next slide, and this is probably the slide that can be a little busy and confusing because the causes of cancer-related cognitive impairment are multiple. So, for example, when we started this talk, I talked about chemobrain and the effects of chemotherapy on different systems of cognition. We know chemotherapy can cause some direct neurotoxic effects. So for example, some chemotherapies can cross the blood-brain barrier. So the blood-brain barrier is a barrier of circulation for the brain, and there's a filtration system to help keep toxins out of the brain tissue itself. Some chemotherapies can cross that barrier and can cause cell death in healthy neurons that are key to memory function. Radiation therapies, hormonal therapies can also cause cognitive problems. Hormone suppression therapies, particularly of brain estrogen, we know can suppress verbal memory. So estrogen in the brain is associated with better verbal memory performance. As far as TKIs are concerned, TKIs tend to affect some of the vascular endothelial function. So circulatory effects can result in some cognitive impairment, although we aren't quite sure that's the mechanism yet. There's also pro-inflammatory cytokines that can affect memory performance, particularly the performance of the hippocampus, which is a seahorse type structure deep in the brain that's responsible for consolidating memories. Pro-inflammatory cytokines are released when there's any invasion in the body. And it appears that cancer itself can spawn this. Brain-derived neurotropic factor is also, it's a protein that is encoded by the BDNF gene. And if there's a mutation in that gene, brain-derived neurotrophic factor doesn't work well. And this protein is responsible for the healthy maturation of brain cells that are involved in memory. There are also genetic predispositions. If you look at the bottom of the screen, it says ApoE4 allele. The ApoE4 allele is a genetic marker that people who are positive for that, who have had sport-related concussion or have gone through open heart surgery, tend to have more cognitive problems than people who aren't positive for that marker. Now, early breast cancer research suggested that ApoE positive individuals may have more vulnerability for cancer-related cognitive impairment than those people who aren't positive for this marker. However, later research showed that that was mixed. So it may be a combination of several factors that I've just gone over that leads to persistent cognitive impairment with cancer. And some individuals may, during their course of treatment, have some cognitive problems, but they tend to clear up over time. We're going into the next slide. Certainly, people that have some underlying health conditions, or if they've had educational problems, are at greater risk for cancer-related cognitive impairment, or people who've had a family history of dementia. And I mentioned depression, anxiety, or a substance abuse history. These factors can influence cancer-related cognitive impairment or make people vulnerable for this. When patients first either come to me or they talk to their doctor about that, we want to rule out some of these things such as anxiety or anxiety disorders or depression. These are readily treated. If you find that you might have depression or an anxiety disorder, if that's treated and the memory problems clear up, great. If they don't, then we can go on to more formal evaluation and treatment for the CRCI. Protection factors include high education. People who've had a lot of education or use a lot of cognitive activity daily tend to be at lower risk. People who are physically active, so if you have a regular exercise schedule, that certainly helps. And of course, normal body weight and reduce your risk with substance. If you don't have a substance abuse history, that will help reduce risk. I'm going to the next slide. And so cancer-related cognitive impairment is real. I told you before that many of the neuropsychological test scores indicate there are mild to moderate symptoms. And if we look at the neuropsychological test scores themselves, even though individuals who have a cognitive impairment from their cancer, compared to healthy controls, they have a slight decrement, but they may still score in normal ranges on the tests. So many people have raised this controversy. So if you're scoring normal on neuropsychological tests, where's the impairment? The problem is neuropsychological tests are conducted usually in a very quiet setting. You try to be as awake and alert and give your full attention to those tasks. When we're working in daily life, we have varying levels of stress and varying levels of demand. That's why I'll go to the next slide. And in this slide, you should see some images of brain. And this is a study that we conducted far back in 2007 of identical twins. And what we were wondering was, what would their test scores be like? Would they be similar? And would the person who went through cancer and chemotherapy have different brain activation patterns when they were doing a task in the MRI scanner versus the twin who didn't have cancer? So the twin on the top, these are 60-year-old women. The twin on the top had breast cancer and chemotherapy. The twin on the bottom didn't. She had a clean bill of health. They were both otherwise healthy individuals. The twin who went through breast cancer chemotherapy was 18 months post-chemotherapy, was taking tamoxifen. And when you go left to right in this picture, we had each of the twins do a task where they wore a set of goggles inside an MRI machine. So in their visual field, they'll see a letter go by in their visual field left to right with a string of letters. And every time they saw the target letter, they'd press a button. And then we had asked them to only press the button when it's 1 back or 2 back or 3 back. So left to right, the task gets more difficult. As you can see, the twin on the top is using more brain with that orange and yellow lighting than the twin on the bottom, who's using less brain. And they both perform the same on the task. The only difference between the twins was the twin on the top was reporting on her self-report measures more cognitive problems and more distress about her problems. So it's as if the brain is working harder to get the same performance out. So this is why many patients will report, I'm fine under normal conditions, I can get my job done, I'm efficient, but if a couple of extra tasks are loaded on top of their daily work tasks, they tend to have more difficulty in this subjective sense that my brain is just working harder. Fortunately, we were able to replicate this study with many other studies with larger samples, and it was replicated across several studies. So there tends to be mild cognitive impairment, but physiologically, the brain tends to be working harder to compensate for other regions of the brain that might have been damaged. And that's why we have the images there. I'm going to the next slide. So I'm just going to go to the next slide. So I'm going to move along quickly here. So nothing was known about cognitive dysfunctions with tyrosine kinase inhibiting therapy. We hope we can get more of this research done, maybe do some imaging studies down the road. But I just wanted to summarize and go over what is cancer-related cognitive impairment, what are the physiological causes, and what are some of the responses in daily life. Now we'll hand it over to Dr. Dunsing, who will take us through the early research on GIST patients with cognitive complaints.
Okay, thank you, Rob. That was a great introduction. And so I'll move forward. Oh. So with all the introduction and my background with the patient advocacy groups, as I just noted in earlier, we thought that we really needed to involve you in our studies to get sort of an intake or a status quo on what is actually happening in GIST patients. So we had addressed you that you should participate in our research, and what we did do here is we started a survey to use one of those patient-reported outcomes that Dr. Ferguson just mentioned, an extended questionnaire to ask GIST patients about their cognitive impairment, but also some other measures that I will go into and that he has mentioned already. So I just wanted to quickly note not only that, let me actually turn on our little laser pointer here. This is how the screen looked like, but also say a big thank you to Dr. Bofberg and Dr. Snitz, who I've mentioned before in the introduction, who were the ones that really helped the study along in the very early time points. So I hope to go to the next slide here, which is not, okay. So let me briefly introduce our study to you and what we were asking the patients. This was a completely web-based study, as I said before, completely anonymized, and the questionnaire could only be answered once from one IP address. So what we were asking were first some demographic questions that helped us characterize the patients that participated in our study, similar to some of the medical history pertaining to the GIST diagnosis and the medications that the participants were taking. And then going on to the actual questions that were included in our questionnaire, this so-called FAG-COG questionnaire, that is really asking about perceived cognitive function and the impact on quality of life. And going further down, so this was a very big part of the questionnaire, actually. And then going further, Dr. Ferguson had mentioned that the cognitive impairment sometimes goes along with other things like anxiety and depression. So we wanted to know about these issues in our participants as well. So we added on a few more questionnaires, and these only had 8 questions each about anxiety, depression, fatigue, sleep disturbance, and pain. And we ended up with another questionnaire that is oftentimes used in the field, just in medicine, actually, the so-called SF-36 questionnaire. And this is a more standardized version to ask for sort of general health problems like heart disease, diabetes, and all of these kind of things. So in total, we ended up with 134 questions. Then to go on to our survey, this was distributed essentially worldwide. So we really relied a lot on the patient advocacy group, like the LAFREF group, but also Just Support International and the Just Cancer Research Fund here in the US, who distributed the survey through the email, their website, Facebook, and so forth. And then some of you may know the sort of sister organization in Europe, Spain, who also promoted the survey through their newsletter and Twitter. So everything was essentially just social media, which was another kind of cool point in our survey, actually. This whole survey was posted for 3 months in the year 2018. So to summarize our participants, we had 859 patients click the link, which is a lot and a lot more than those 4 patients that Dr. Ferguson just mentioned in that one study. Unfortunately, one patient needed to be excluded due to his or her age. And then we had some loss in respondents of people that either did not complete any items or did complete less than 90% of the questions. We speculate that some of this is due to the fact that people may have clicked on the link from 2 different IP addresses. They checked out the survey at work and maybe started it a little bit, but then they thought, okay, I need really some time to finish this, and completed this at home. We have no way to prove this, of course, but this is one possibility. So all in all, 485 patients or participants completed more than 90 and more % of the entire questionnaire, which we thought was great. So to quickly go over who these participants were and what their characteristics were, we had a mean age of 57, almost 58 years, which kind of fits the GIST patient community because it's usually cancer diagnosed at a slightly older age. Interestingly, we had about 70% of the respondents being female and about 30% of them being male, which is actually seen, as Dr. Ferguson told me, in many of these type of questionnaires. Then going further to ethnicity, most of the respondents were Caucasian. Looking at where they lived showed us that most of them lived actually in the United States and Europe, like North America and Europe. It's not moving. Oops, okay, now it's moving too fast. I'm sorry. Okay, so looking here at the country of residence, so mostly United States, Europe, but also people from Asia, Australia, and even Africa responded to our survey. We had a highly educated group of people, of participants. Most of them had 16+ years of education and were in higher level of occupations or not in the current labor force, which can be one of 2 things, either that they were retired, for example, or not working. We could, with the help of the so-called Verona index, by the questions that we did ask, we could use the answers to estimate an IQ, and the so-called full-scale IQ that our sample had was very high, with an IQ of 110. So then getting into the more clinical parameters with respect to the participants' GIST, most people were quite a few years out since their diagnosis, over 6 years. And we also asked what kind of medication the participants were taking for their GIST. And most of them actually were taking imatinib, Gleevec. What I'm showing here in the pie chart is only the drugs that participants not on Gleevec were taken. And as you can see, more than half of that, more than half of the participants were taking sunitinib, Sutent, and then another, about a quarter of the patients were taking the third-line drug, Stivarga or regorafenib. And then about one quarter was made out of all kinds of drugs that the participants were taking. They were part of clinical studies, for example. Interestingly, a handful of the participants were taking one of the new drugs, ripretinib, DCC 2618, and also just a few participants were taking Lu 285 avapritinib. So now coming into the perceived cognitive impairment that was reported, and you could see here in the graph, the top bar is looking for the perceived cognitive impairment that the patients reported. The high number is 72, which would mean no cognitive impairment. So the mean cognitive impairment of our participants was half of that, so that is quite reduced. And a lot of the participants reported that this affected their impact on quality of life. If you look at the lower bar here, this is measured in a scale 1 to 16, and anything that is like lower than 10 is supposed to be clinically significant. So the mean impact on quality of life score was 7.7. So this is quite low, and actually about 2/3 of the participants scored lower than 10. So meaning that quite a high percentage of participants had an impact on quality of life through their negative or through their cognitive impairment. Through further correlative calculations, we could find that this perceived cognitive impairment actually correlates with the quality of life, and we could show that participants with a low impact on quality of life scored high on the perceived cognitive impairment, meaning that they had not so much or reported not so much cognitive impairment, and vice versa. So people which reported more impact on the quality of life scored worse with respect to their cognitive impairment. And all over, looking at both of the gray bars here, the numbers were comparative to what we see in breast cancer patients. Interestingly, perceived cognitive impairment did not correlate with the IQ of the participants. And in first correlative studies, we did not see that the cognitive impairment correlated with either time to diagnosis, the first GIST surgery, or when they started Gleevec. So right now we are in the process of further analyzing those data, not only with respect to whether at the time of the survey the patient was on or off therapy, but also with respect to what kind of therapy the participant was on. For example, if they were on Gleevec or some of the second or third line therapies, or on an experimental therapy. Interestingly, however, and if you remember what Dr. Ferguson said earlier, oftentimes for other cancer entities or perceived cognitive impairment correlates with, say, anxiety and depression. We did not see that in our study. However, age correlated with some of those measures. So just to conclude really quick, this was the first large study on cognitive impairment in the GIST as well as the sarcoma population. We demonstrated it's feasible to do this as a web-based study. We confirmed that about 2/3 of the patients reported significant impact on quality of life. However, that we have no correlation to certain other measures, but that survivors 5 years or more since the diagnosis reported worse cognitive symptoms. I did not really show that, but that's what we found, independent of the TKI therapy, suggesting that there are cumulative effects of the long-term treatment. So again, the results are comparable to breast cancer survivors, but what we will need are further investigations and actually correlations to actual neurocognitive testing. And this is something that we have moved into right now. So with that, I would actually hand it over again to Dr. Ferguson.
Dr. Ferguson, can you please unmute yourself?
I think I just disclosed my own cognitive impairment with operating the computer. I wanted to advance to the slide that is a white background and says, is there any possibility to help with cancer-related cognitive impairment? And the quick answer is yes. There are ways to do that. And fortunately, for the last probably decade, we have begun to investigate with higher quality studies various treatments of cancer-related cognitive impairment. Go to the next slide. First of all, physical activity. For those people who run or walk or hike or bike, aerobic activity is good for cognitive health. The jury is fairly back on that across the board, regardless if one has gone through cancer or has had a cancer diagnosis. Aerobic activity is good for cognitive health. There are also non-aerobic exercises that look promising. For example, yoga in one controlled study looked as though it helped reduce pro-inflammatory cytokine circulation, as does aerobic activity, and an improvement in cognitive function. So physical activity most certainly will help. There have been a couple of pharmaceutical trials. We go to the next slide, it says medication. There are more studies in the pipeline regarding various pharmaceutical treatments. I guess first what was tried was drugs that have treated attention deficit disorder, so a long-acting type of methylphenidate called dexmethylphenidate or Focalin. Was trialed way back in 2008. This was a set of breast cancer survivors. This was a sample that was undergoing chemotherapy, and it was only an 8-week trial, so it was rather short. But there were some neuropsychological test scores and improvement in attention. The one downside was the side effects. About 40% of patients who were in that trial reported headaches, and about 27% reported nausea. So with many of the patients with cancer that I've seen over the years, one of the downsides of medicine is adding another medicine. I'm going to stay on that slide, excuse me. modafinil or Provigil. Modafinil is a drug that's been approved by the FDA for excessive daytime sleepiness. And in one placebo-controlled trial, there are 68 breast cancer patients who are at least 22, about 23 months, almost 2 years past their last chemotherapy infusion, who had persistent cognitive impairments. And improvements in speed of processing were found on a computerized neurocognitive test. And one of the limitations of that study, there was no long-term follow-up. So how long do people have to stay on this therapy? But most certainly, modafinil helps with fatigue. So for those patients who have persistent daytime fatigue, it could be a pharmaceutical answer for that, but it's not for everyone. And again, the downside is for many patients with cancer report, I don't need another pill in my regimen. I'm going to move to the next slide. And the next slide has to do with cognitive rehabilitation programs that are computerized. Now, a lot of people have asked me about, should I do, computer games? Should I do video games? And that will help with processing speed. And we certainly have one computerized program here that's on the screen that was trialed. It consisted of doing 40-minute sessions, 4 of them per week, so about 40 hours of training. And there were improved processing speeds, and the computer program would always adjust the difficulty. So if you got 80% or more of the cognitive computerized tasks right, it would increase the difficulty of the items that you would do, and it would adjust accordingly. And the idea was to get more neural networking with a lot of cognitive activity. The one downside to these approaches is that you become very proficient at the video game or the computerized task, but it may not help you remember what was said in that meeting at work, or remember that appointment that you had with a friend going out to dinner. So it doesn't generalize from the context of the video cognitive drill and practice to real world activity. I'm going to go to the next slide. Memory and attention adaptation training. That's a mouthful. This is a cognitive behavioral therapy developed by myself and Dr. Karen Gillock, a colleague of mine in New Hampshire. We started this program back in the early 2000s and been developing it. So cognitive behavioral therapy is a term you might have heard. Cognitive behavioral therapies help manage thinking and behavior. And the idea is to help people get out of thinking habits that can maintain distress in daily life, as well as change behavior. And the reason we use the cognitive behavioral therapy approach for cancer-related cognitive impairment was all of us use our memory to complete daily tasks. We want to be able to perform. So what we did was we turned it on its head. Instead of trying to train the brain to have better memory, what we did was we helped people identify those tasks in daily life they want to do better with, and to help them improve their performance. So this cognitive behavioral therapy consists of 8 visits of about 45 minutes in duration. It can be delivered over video conferencing. We've done this for years this way, so it's nothing new with us with COVID-19. It's business as usual. And the good news is, I'm going to go to the next slide, that we've gotten some positive results. We have 4 components of this. We teach people about memory failures in daily life, and the fact that even though we've gone through cancer and we might have more memory failures, the brain is programmed in human beings to have some memory failure. The idea behind that, what neuroscientists believe, is that we want to be able to sort out and prioritize those memories, and those learning experiences are going to be of value from those that we really will just clutter the attic. So we go over some memory failure education. We also help people become more self-aware of where and when their memory failures that bother them occur. And what happens is usually patterns emerge. So many people have memory failures at the end of the day, or they might have them at a particular job task, but not other job tasks. So we kind of focus our efforts on training those areas where there's problems, leaving the other areas alone. We also teach stress management skills and then a bunch of cognitive compensatory strategies, such as using a day planner, using it efficiently and consistently, teaching people to self-instruct, so talk out loud as you're doing some task, particularly with procedural steps, or using visualization memories, having another part of the brain compensate for areas that might have been damaged. We go to the next slide. On the left, you'll see some tiny blue lines going up. That's our MAT treatment group that improved in neurocognitive scores, both in self-report and in our processing speed neurocognitive measure. We also saw improvements that were sustained over quality of life versus a control group that had supportive therapy. So in the presence of a supportive counselor, patients did better, but not over the long haul. So the conclusion that we drew from that was, once you learn a set of skills of identifying and managing memory failures better in daily life, you can improve memory performance in daily life and hopefully sustain better quality of life for a longer period of time. I'm going to go to a conclusion slide. Before I get into a little bit of COVID-19 tips and dealing with that, particularly as someone with cancer. Cancer-related cognitive impairment has multiple mechanisms. And I want to stress that they can be long-lasting, mild to moderate symptoms. They don't tend to be progressive in most people, and it's not everyone. Simply because somebody has a cancer diagnosis, goes through cancer treatment, that's not a guarantee that you're going to end up with cognitive impairment. In fact, it might be a large minority of people, but it's not, certainly not everyone. We're now just beginning to investigate CRCI and GIST and the potential effects of TKI therapies on memory function. And certainly, if you lead a healthy lifestyle, that's a great protection factor. And the place to start is to talk to your doctor or medical oncologist about cognitive problems if you have questions about it. Rule out the simple things first. If you still have persistent problems after ruling out either medical causes or anxiety problems or depression problems, then you can get a referral to a neuropsychologist or clinical psychologist that might have some expertise in this area. Okay, this is the part that I was asked by Sarah early on to address in coping with COVID-19. I see a lot of patients at the UPMC Hillman Cancer Center. We're doing everything via video conference. And you can imagine the disruption that sheltering at home has caused in all of our lives, but particularly those who have cancer or are going through cancer therapy. I think the first thing that's most important is to keep a regular routine, a regular bedtime and a regular wake time. Why is that? Circadian rhythm. Our body has a biological clock. It's actually centered in the brain. And we know that when we keep the circadian rhythm on schedule, that actually cognitive performance improves. And also you want to stimulate, or rather simulate a work day to keep that schedule as regular as possible. Even on weekends, you might sleep in an hour longer, but try to keep as regular in bedtime and wake time as possible. Keep your tasks, set goals every day. Get up, get going, make your bed. Address every day as though it was a work task. And you want to schedule fun and recreational activities that are just as important as your work activities, and time to relax. Certainly time to exercise. You may have to modify it with some of our restrictions now. But keep up those habits. There are good applied relaxation exercises on the app Breathe, which you can get on your mobile phone. These are helpful for regulating your autonomic nervous system, which is the fight or flight nervous system. And doing that every day would be important to get a good baseline of learning how to cultivate and regulate stress arousal. I always have patients identify the real risks involved. Now, nobody knows that much about this virus that we can predict just how deadly it is. But the last data I checked, that we had almost 1.5 million cases, but these are measured cases in the United States. New serologic data, or how many people that have COVID-19 antibodies, are coming out that suggests that the rates of fatality are much, much lower because this virus has spread much. So while this is a scary virus and we need to wash our hands, keep distant for now until we get a vaccine, but as we become more active, because we have to, we're understanding that in greater likelihood of things, it's a very, very small probability for most individuals that this disease would be fatal. At the same time I say that, it's just important to keep up the good common sense, hand washing, wearing a mask when you go out so you potentially don't infect others. For those people that are patients with cancer, it appears that those with hematologic diseases that are getting immune suppressing therapies in particular may be at greater risk, or those with lung cancer may be at greater risk because of lung physiology and inflammation. Certainly people who are older, who have cancer over age 65, may be a little more at risk, or those people on drugs such as Keytruda, or who've had chemotherapy in the last 30 days. That last bit of data is just very new. I don't know if that could be replicated, but those individuals may be at greater risk, so take extra precautions. At the same time, you shouldn't be frightened. You need to go get your therapy, talk with your doctors and nurses about the proper precautions, and proceed. And again, I'll just close by saying masking, distancing, hand washing. Our clinic is going to start accepting patients on an outpatient basis. Our cancer center has been open for most of the patients who are in active treatment all this time. So on that note, I will stop talking and we'll be open for any questions that Sarah. And I'll go to the last slide and just want to thank our collaborators. There's too many to thank. They're all wonderful people and work very hard. And I want to thank Dr. Dunsing for introducing me to this group, and Sarah and everybody for having us today.
Great, thank you very much to the two of you for an excellent presentation. So for those who are on the line, I encourage you to go to the bottom of your screen. There's a Q&A icon and you can type in your question for me to ask the presenters. I know we are past the 3 o'clock hour, but I'm going to save some time for questions. So the first question that we have is, what is the impact of successive surgeries, anesthetics, hospitalizations on cognitive function? All seem designed permanently to alter sleep patterns. In older patients, this combination can result in weeks of recovery, including feeling like oneself having emerged from a fog. So do you have any thoughts on that?
Yeah, certainly surgery and anesthesia can have, for most individuals, can have a short-term impact, but multiple surgeries have been demonstrated to have some mild cognitive impact over time. And in fact, one of the controversies in our longitudinal research is that we don't often get a true baseline prior to the person getting chemotherapy, they've usually had a surgery. And that surgery is usually scheduled not long after biopsy and diagnosis. So we can't squeeze in neurocognitive testing before that. So it could be the effects of anesthesia and surgery that also contribute to some of the cognitive impairments we've observed in our research.
Okay, in a slide that you presented about the prevalence of 50% of individuals and then as many as 40% demonstrate cognitive dysfunction at baseline, is this saying there is an underlying cognitive dysfunction that is exacerbated by treatment? When is the baseline dysfunction measured? Pre or post cancer diagnosis, pre or post treatment?
That's a really good question. I sort of just answered it.
Yeah.
Most of the time we're getting the testing done at the time, right after diagnosis, but oftentimes after a surgery as well.
Okay. Do you see progressive impairment the longer a patient is on Gleevec?
Dr.
Who
Dunson?
wants to take that one?
Yeah, sure. Yeah, we do see that. I think I maybe fairly quickly mentioned that at the end, that we see more cognitive impairment the longer the person is on treatment. Interestingly, though, and this is also in contrast to other studies, we see depression go down the longer a patient is on treatment. So there may be more hope at this point for the patients.
Somebody just said, does imatinib use worsen Alzheimer's? Some caregivers have noted declines in advanced patients. Do you have any information on that?
Rob, do you want to say something?
We don't know at this time. And the data that we have with the patients who have, most of the patients we saw in our study who were on some type of TKI therapy, and we know those who had longer survivorship reported more cognitive complaints. But we don't really know at this point if that's because of the TKI therapy or having just longer. So it's hard to say if it's the TKI therapy, the GIST, or some combination. And we're now in this field beginning to study the effects of people that have other cognitive impairment and who may be susceptible. There is a large multi-site study with breast cancer that is evaluating patients who are later life individuals who also may have Alzheimer's. And we are finding that the cancer-related cognitive impairment makes that condition worse, and it may exacerbate some. We don't know that in GIST yet. We're pretty far off from getting there, but it's a concern.
Yes, I mean, definitely. So we would have had to, for example, ask if anyone, like in our survey, we could have asked if anyone would have had Alzheimer's, for example, but unfortunately, we're still at the beginning of those studies.
I'm going to ask you a question. You might not know the answer, but I think it's on a lot of our patients' minds. So one person has noted, my husband has been on avapritinib since 2016 and will stay on most likely for a long time. Is this cognitive impairment likely to be permanent, or would it diminish if he eventually starts a new treatment?
Yeah, I can take that. This is a very good question, and actually both Dr. Ferguson and I, we have been in contact with Blueprint Medicines. They're actually very interested in working with us on this issue of cognitive impairment that is seen with their drug. Unfortunately, new study results of their clinical trials have found that a dose reduction or a drug holiday, so to speak, for 7 to 14 days actually leads to bettering of the cognitive impairment or even a reset to baseline. Having said that, one could extrapolate that once a patient stops avapritinib and moves on to a different type of therapy, that the cognitive issues will kind of decline. However, one does have to say, obviously, that we don't necessarily know about another time factor for how long a patient has been on that drug. Like, it could be years, and if the same is still true if a patient stops the treatment after years. But in generally, it is true that it will get better, actually.
Have you seen cognitive impairment varies with dosage, like the Gleevec dosage?
This is just another thing that we address. We did ask a question in our survey what dose the participants were on. So that's just something that we can analyze by looking at our data.
I have a question. Did you use a control group to determine if age rather than Gleevec contributed to the decline in memory after long-term treatment?
That's something for Dr. Ferguson.
No, we didn't have a control group. This is purely a survey study. And I believe that we didn't see an association. Did we? I can't remember. This is another cognitive failure on my part. Was age strongly correlated with cognitive impairment? I don't believe it was in our sample.
I don't think so either. And I think you have always mentioned that the questionnaires also that we do use, they're kind of normalized, right, to the normal population, including an older population. So but we did not see anything there, I believe. Good question, though.
How often is it recommended to assess cognitive impairment in patients undergoing treatment?
Well, we hope in the future that this would be more of a standard of care. There's new technology to make the neuropsychological tests less unwieldy and a little more convenient. So there may be some standardized tests we could do on an iPad that requires very little staffing time to do that with the patient. And so in 20 minutes versus an hour or two. And it would be great to have cognitive testing done at the time of diagnosis and then once every 3 months. We do have a pilot study where we are doing that currently. And it's a phone-based brief neurocognitive assessment. So it's entirely COVID-19 proof. Nobody has to leave their home, and it's a validated and reliable measure that can be done on telephone. Whether or not we get good results, and that's proven to be, or at least demonstrate to be reliable and valid, and we see any changes over time, perhaps that might be a practice we could implement clinically, but we're pretty far off, and it depends on the cancer center you are at. I know my colleagues at Lee Moffitt Cancer Center in Tampa commonly have, for particularly in those patients that are doing some of the newer therapies, such as CAR T-cell therapy, it's fairly standard there. They do a brief neurocognitive battery before the patient undergoes therapy. And then I think it's several months intervals. If you do the cognitive testing too much, you got to be careful of practice effects, because then it doesn't look like there's any decline. So if somebody's performing the same over repeat measures, they may be hiding a decline because they aren't gaining as much as somebody without an impairment.
It's interesting because somebody commented that they know that there's foggy brain and it's a thing, and it gives them reason to be a bit more mentally lazy. That was one of the comments in the chat. But I just want to conclude because we are over time, and I think you just alluded to some of your current projects, but I think you sparked, from what I'm seeing here in the messaging, a lot of interest among our community about the research that you're doing. And so I think that there is some interest regarding some of your upcoming projects, like the one you just talked about, and if current GIST patients are able to participate. Can you comment on that?
Yeah, sure. So at maybe Rob has something to say afterwards as well. But currently we are only or have open our current trial only at the UPMC Holman Cancer Center, and we are opening another quick study, hopefully later this year, also localized here for now, but we are talking to collaborators at Vanderbilt, for example, who would like to kind of join in and also expand the study to there.
Great. Okay, so we're going to conclude this webinar today. I want to thank you both for your time and your expertise that you've shared with our community. And to all of you who have joined during your busy days, thank you very much. We hope that you continue to activate your mind and to take breaks to help manage stress. And we look forward to having you tune in to our next webinar at our next series, which will be June 16th, regarding how to understand your pathology report. So everybody, thank you very much and have a lovely day.